Hi, everyone. Just giving folks a chance to hop on the call. And I'll get started. Good afternoon, everyone, and welcome to today's Research America Alliance discussion. My name is Tori Schneider, and I'd like to thank you all for joining us on Zoom today and for your partnership in the Research America Alliance. If your organization is not a member of our alliance, I hope you'll reach out to Kristen Furlong, Director of Membership and Development, whose email is in the chat, for more information about joining our alliance. Today, we are joined by Dr. Lyle Petersen, Director of the Division of Vector-Borne Diseases, Dr. Monica Parise, Deputy Director for Science and Program, Division of Parasitic Diseases and Malaria, and Dr. David Fitter, Director of the Division of Global Migration Health, from the CDC National Center for Emerging and Zoonotic Infectious Diseases, or NCEZID. Today, we'll be shedding light on the increasing threat of dengue and other tropical diseases here in the US. And this is a topic as a past malaria researcher that's very much of interest to me. And so I really hope that everyone on the call today will learn something and get some new insights on this growing issue. So as always, please feel free to type your questions into the Q&A box or chat, and we'll get to them during the audience Q&A portion of today's session. And thank you again so much for joining us, and I'll turn it over to all of our experts.
Yeah, thank you. And as Tori mentioned, I'm Dr. Lyle Petersen. I'm the Director of the Division of Vector-Borne Diseases, and I would like to start our program today. And then I'll be followed by Dr. Monica Parise, Deputy Director for Science and Program, followed by Captain David Fitter, as the Director of the Division of Global Migration and Health. Next slide. So first of all, good afternoon, everyone. And I'd like to thank you for the opportunity to present to you on how CDC is addressing neglected tropical diseases, otherwise known as NTDs, in the United States. My co-presenters and I come from different divisions within the National Center for Emerging and Zoonotic Infectious Diseases, and we'll each be talking to you about a complementary topic related to the theme of tropical diseases in the United States. And before I dig into the problem of invasive mosquito-borne viral diseases in the US, which I will be talking to you in a minute, I'd like to offer a very brief introduction to the National Center for Emerging and Zoonotic Infectious Diseases, which I mentioned houses each of our divisions. So we're the largest infectious disease center at CDC, and we have 8 divisions and about 4,000 employees and contractors. And the mission of our center is to save lives through the prevention, early detection, and response to infectious disease threats. And as a center, we deal with all of the topics listed on this slide, here from A to V, and a great many more. And from the routine and familiar to the rare and scary, much of it resides in our center. And our scientists and programs provide both cross-cutting support for infectious diseases in general, but also very pathogen-specific subject matter expertise. Next slide. So why are all these diseases that we deal with increasing? And there are a lot of driving factors, and I'll go into this in a little bit more when I talk about dengue. But for one, the world is increasingly crowded. It's estimated there will be 11 billion people on the planet by 2050, many of whom live in megacities encompassing 10 million or more inhabitants. The world is also increasingly connected. One can almost travel to any major urban center in the world within the incubation period of most infectious diseases. And there are 2.75 billion airline passengers globally. And global supply chains are increasingly global, touching 50% of fresh fruit, 80% of seafood, and 80% of active drug components. And in many cases, the worlds that used to be separate are now converging. For example, the world of animals, agriculture, and humans are converging, which is what's known as spillover, where where infections that were in the environment now spill over into humans. There's also increasing demand of megacities for fresh food, and humans are encroaching on wildlife habitats. Finally, we're seeing the role of extreme weather events exacerbating these situations. So next slide. So now I'd like to talk about one of my areas of expertise, which is invasive mosquito-borne viral diseases in the United States. Next slide. So on this slide, I have a timeline of mosquito-borne pathogens identified in the United States that cause human disease from all the way back from 1650 to last year. And there's this scale here that you see on your right is not linear. So just take note of that. But some of the diseases, first diseases that came in, and the ones that are circled in red are all invasive diseases, diseases that really do not belong in the United States, but are now here. The first was yellow fever virus, which came in from the slave trade from Africa back in the 1600s. Then was followed by dengue, probably by similar kinds of mechanisms from Africa. And then there was a pretty good hiatus until more recently when we saw other invasive mosquito-borne diseases coming in, such as Venezuelan equine encephalitis virus, the West Nile virus, which now accounts for 90% of mosquito-borne infections in the US, chikungunya, which causes crippling arthritis, and most recently Zika virus. So as you can see that the pace of things coming into the United States is increasing. Next slide. So what I would like to do is talk about dengue. And if you remember from the last slide, this has been around in the Americas for a pretty long time, but it's now having a huge resurgence. And many of you may not have heard about dengue, although it's been in the news recently for reasons which I'll talk to you in a minute. But this is a mosquito-borne flu-like viral illness that can be fatal, particularly in children. And it's pretty unique among the mosquito-borne viruses in that it almost exclusively spreads from human to mosquito to human. There are actually 4 dengue viruses, which are known as serotypes, labeled dengue 1, 2, and 3, and 4. The inventors of these weren't too original. But the thing about dengue is it causes a lifelong dengue type specific immunity. So let's say if you're infected with dengue 1, you can no longer get dengue 1, but you can still get dengue 2, 3, and 4. So you can get dengue actually 4 times in your life. But infection with one of them, such as dengue 1, will cause you to be immune for life for that virus. But it will also cause a very short-term immunity lasting a few months or a couple of years to the other 3. But if you do get infected after that immunity wears off and get infected with a second dengue virus, it increases the risk of severe dengue, likely due to something called antibody-dependent enhancement. And the 2 mosquitoes that primarily spread dengue I've pictured on the right of this slide, Aedes aegypti, which is also an imported mosquito from Africa, does not belong in the Western Hemisphere, but it's widely prevalent throughout the Western Hemisphere, in tropics and subtropics. And this mosquito has adapted itself to humans, to particularly biting humans, and uniquely biting them indoors. And so it's a very formidable threat. The other mosquito is something called Aedes albopictus, which is the Asian tiger mosquito, which was brought in from Asia into the United States in the mid-1980s by the importation of used tires. Fortunately, this is not as big of a threat as Aedes aegypti. Next slide. So what's happening with dengue? As I mentioned, it was brought into the Western Hemisphere, into the United States in the 1600s, but you can see from this slide, which shows dengue incidence in the Americas from 1980 onward, it's been going up and up and up. And in 2023 was by far a record year for dengue. And then the bright red bar is what's happening in 2024. so far. And even though we're only halfway through the year, we almost doubled or more than doubled the what happened in 2023, which was the previous record. So you can see from this, dengue is getting worse and worse and worse, with more than 9.6 million cases already reported in the Americas through June 20th. Next slide. And so now in the Caribbean, most of the cases that in 2024 were in the Southern Hemisphere because that was their summer, but now we're entering summer in the Northern Hemisphere, and this is what's happening in Puerto Rico. And on this slide, you'll see a gray line, which is the average incidence of dengue by week. And in the squiggly blue line there, near the gray line, is what happened last year. And then the darker blue line is what's happening this year. So the same thing that's happening now in the Caribbean happened earlier in the year in South America. And that red line indicates what we call the epidemic threshold. So we're way above the epidemic threshold already, and we haven't even gotten anywhere near peak dengue season in the Caribbean, which generally occurs around September, October. So next slide. So with all of these cases of dengue occurring throughout the tropics and South America, that any traveler can bring dengue back into the United States. And we typically see about 1,600 to 1,800 imported dengue cases a year that we actually identify. And this year we've about tripled that number so far. So many more people are coming back with dengue into the continental United States. And anywhere where there's the vector mosquitoes, Aedes aegypti or Aedes albopictus, an imported case can then cause local mosquitoes to get infected and then cause local cases of transmission of dengue. Fortunately, outbreaks of dengue primarily happen in southern Texas, southern Florida, but as indicated on this map, they can happen anywhere, and most recently occurred in California and in Arizona for the first time ever. Next slide. So why is dengue going up so much? And there's a variety of factors. Back in 2003, the Institute of Medicine developed this convergence model indicated on the right, indicating that a variety of social, political, economic factors, genetic factors, physical, environmental factors, and ecological factors combine to interact with humans and microbes to cause these emergent events. And many of the topics that they outlined as drivers for disease emergence are now happening with dengue. So for example, with climate and weather, we are experiencing heat waves like none other right now. And warmer weather promotes viral transmission in mosquitoes. We're also changing ecosystems, but as I mentioned, we're also living in more crowded places and people are more traveling around, which for a mosquito-human transmission cycle, if you want to spread dengue, have people move around, and that's exactly what's happening. Next slide. So this just illustrates what I've already mentioned previously. There's been a rapid increase in human travel. And so any airline passenger who picks up dengue one place can go to another place and spread that virus through mosquitoes that bite that person. Also increasing urban populations, as we mentioned, about more than half the population now of the planet now lives in urban centers. And since this is a mosquito-human transmission cycle, when you start crowding people together, along with the Aedes aegypti mosquito, which likes to live in crowded and urban environments, you have the perfect storm for spreading this virus in populations. Next slide. So what are we doing about this? We've recently developed a Vector-Borne Disease National Public Health Strategy, which was authorized by the Kay-Hagan-Tick Act in 2019, and which was both led by Health and Human Services and the CDC. It was built along the upon the National Public Health Framework, which we developed a couple years earlier. And this was a general effort to really address these mosquito-borne and tick-borne diseases that are emerging in the US in a very comprehensive way. So we had 17 collaborating federal agencies all working together to develop this national strategy. Next slide. So we at the National Public Health Strategy for Vector-Borne Diseases outlined a vision where a nation where vector-borne disease is no longer threatening public health, and a mission of protecting people from illness, suffering, and death due to vector-borne diseases. And it outlined 5 basic goals, in which I won't go through them in detail, but basically it was better understand where people are getting infected, better evaluate tools and methods to diagnose them, better come up with ways to deal with them and treat them, and finally to develop national capacity to control them. And so with those 5 goals, but under those 5 goals, there were 19 strategic priorities, 42 objectives, and 124 sub-objectives. So this went into great detail about how the US government should address these vector-borne diseases. Next slide. And looking forward, one of the things we recognized was to implement the national strategy. It involves everyone. It involves not only the federal government, but other public health partners, health departments, academic researchers, policy and decision makers, vector control organizations, academia, and patient advocates. So it's really this combination of this network of individuals and groups working together to try and implement the national strategy, of which we hope to make significant progress in reversing these upward trends. So next slide. So now I'd like to turn the podium over to Dr. Monica Parise, who would talk about ending the neglect of neglected tropical diseases in the US. Monica?
Thanks. Thanks, Lyle, and good afternoon, everybody. So usually whenever people hear the term NTDs, they think of other countries, but I'm going to point out some of the examples of these diseases occurring in the United States and what we're doing about them. Next slide. So the NTDs have been with us for many, many years, and they affect over 1 billion people globally and in the United States, often affecting populations that are already experiencing health and economic disparities. They impair physical and cognitive development, cause illness and death, and affect economic productivity. Lyle already mentioned how, the role of weather in vector-borne diseases. Just also will note that severe weather can impair our ability to address diseases by impairing health services, including vector control services. Next slide, please. So there are 21 NTDs recognized by the World Health Organization, including parasitic, viral, bacterial, fungal, and even non-communicable diseases that are spread by various routes of transmission. So our division of parasitic diseases has expertise in all of these parasitic diseases, but we focus mainly on the ones that are bolded. They can cause a variety of clinical manifestations, including heart failure, blindness, and severe limb swelling or lymphedema. Some of these are transmitted domestically, and many can be controlled through mass drug administration, controlled or eliminated in affected populations. Next slide, please. So just a few examples of what we're doing to address these diseases in the United States. We support the establishment of programs to prevent both congenital and donor-derived transmission of Charlotte's disease in the United States. We're working with the Health Department in American Samoa to both interrupt the transmission of lymphatic filariasis. This is the last U.S. territory that has LF, lymphatic filariasis, as well as working to prevent the disability in those who are already infected. And we're improving our understanding of the transmission of leishmaniasis in the United States, including the risk for introduction of new species. Next slide, please. So neglected parasitic infection is not a term that we use a lot, but it is helpful to describe the group of diseases that are tied together in a few ways. The burden of the disease is poorly defined. We lack good surveillance, and we even lack the tools to assess the burden. There's a lack of awareness among healthcare providers of many of these diseases, and they disproportionately affect minorities and disadvantaged people. Next slide, please. While we don't have a lot of information about their burden, we know enough to identify them as quite significant problems. And this slide, I won't go through all the details on the numbers, but you can see that there is significant burden of many of these diseases in our country. Next slide, please. I'll mention a few of our domestic priorities. We support outbreak investigations. Cyclospora is a parasite that causes intestinal illnesses and is spread by contaminated food and water, as well as you may have heard about the local malaria cases in the United States last year. I'll talk about that a little bit more in a minute. We conduct surveillance for 4 nationally notifiable diseases in the United States: malaria, babesiosis, cyclosporiasis, and trichinosis, and work with state health departments to both detect and respond to these diseases. And finally, our subject matter experts are available 24/7 via our hotline to assist health professionals with clinical management of parasitic diseases, fielding thousands of inquiries each year. We also have several anti-parasitic diseases on CDC's drug service, treatments that would otherwise be unavailable for US patients. Next slide. Let me spend a little bit of time on how we're trying to address some of the health equity gaps that exist for these diseases. Back to Chagas disease for a minute. It's estimated to affect 300,000 people in the United States, and up to 300 babies each year are born in the United States with Chagas disease. Most people are affected in Latin America, and they don't know that they're infected. And they come to the United States and face many barriers to care, including poor awareness among US healthcare providers, as well as the cost of care. Over the past 9 years, we've funded academic partners to develop new strategies and guidelines to raise awareness of this problem among healthcare professionals, as well as populations that are at increased risk. We offer continuing medical education and have informational tools on our website, and we support Chagas disease testing. I'll mention soil transmitted helminths. So these are intestinal worms that are acquired through ingestion or contact with infected soil. For example, hookworm is one example. Since 2018, we've awarded funds to academic partners in Mississippi and Alabama to determine the prevalence and risk factors for soil transmitted helminths in areas that are most conducive to their potential transmission, such as those with the environmental conditions and economic conditions to support transmission. I already mentioned American Samoa. So next slide, please. We're also addressing the threat of NTDs, both globally and in the United States, via innovation and research. I've listed a few impactful examples that I'll mention. We've developed a multiplex immunoassay that can detect antibodies for over 30 different infectious disease agents, providing a very cost-effective way for countries to assess the burden and conduct evidence-based decision-making. We evaluate new tools for vectors to address vectors, especially malaria. Attractive targeted sugar baits address outdoor mosquitoes, while spatial repellents address indoor biting mosquitoes. We're also looking at better methods of larval control and housing modification. as well as novel vector genetic work, including cryopreservation of mosquito larvae and embryos, which can advance research for both CDC as well as a variety of partners. And we're working to improve or modernize our serologic tests, for example, for schistosomiasis. Next slide, please. I'm just going to talk very briefly about malaria before I close. So, next slide. So each year there are nearly 2,000 cases of malaria in the United States, almost all acquired during international travel. Lyle already mentioned travel's been going up. Our cases of malaria have also been going up. Last year, we experienced the first cases in 20 years of locally acquired mosquito-borne transmission. And these cases remind us how quickly a global problem can become a local one. Early detection, prompt action, and proper treatment were essential in limiting local spread beyond the 10 cases in 4 states in Florida, Texas, Arkansas, and Maryland. We supported state health departments in epi, clinical, lab, and vector control aspects, as well as conducted genomic sequencing to better understand the threat. Lyle mentioned that the mosquitoes that transmit, for example, dengue, are present in many areas of the United States. That's the same for the malaria vector, the anophelines. Most U.S. states have those mosquitoes, which also emphasizes why prevention is so important, so that imported cases, people don't come in and infect the mosquitoes that are already here. Also an issue for malaria. Next slide, please. Our scientists have prioritized lab readiness for domestic malaria in a few ways by improving a multiplex PCR test that we'll be sharing with states, by collaborating with the Association of Public Health Laboratories to conduct training, and to be refining our sequencing approaches. Next slide, please. Finally, we get asked about the Anopheles stevensii, so I'll just mention a few words about that. This is an important malaria vector. It's an invasive species that is native to South Asia, but has spread to Africa. And unlike many of the Anopheles mosquito malaria vectors, it can thrive in cities and can persist with little rainfall. So it's new to the African continent. Recent models estimate that an additional 126 million people could be at risk of malaria in Africa if this mosquito establishes itself in key urban areas. This mosquito isn't present in the United States, but if it did arrive, there is a potential to establish itself. Overseas, we're working to address Anopheles stevensii in various ways, including identifying the areas of greatest risk, improving our understanding of its ecology in this new environment and its contribution to transmission, and by helping countries improve their surveillance and control capacity across Africa. I'm going to stop there, and I'll turn it over to our next speaker, Dr. David Fitter, who will elaborate on global migration in NTDs. Thank you.
Excellent. And good afternoon, everybody. And thanks again, as the others have said, for inviting us. I will sort of move quickly through this, but I think you're going to see where some of these pieces are starting to come together. From our division's perspective, we sum it up quickly as saying safe and healthy movement of people. Really, our vision is safe global movement to protect human health. So if we go to the next slide, please. So here we have travel volume. Just looking globally, Lyle said this, Monica said this as well. People are on the move. And so what does that mean? It means we're more connected and people are moving, and disease can also move with them as they're traveling quickly. In the United States, we have approximately 1 million people that come in every day through air, sea, and land. And so that means, how are we covering all those people that are coming in, and how are we preventing disease from coming in as well? From our division's perspective, we're looking at this as preventing and limiting the introduction of communicable disease of public health concern into the U.S., developing evidence-based information and strategies to inform and protect the public and partners, and also detecting and responding to the introduction of communicable disease of public health concern to reduce that burden of disease as well. So if we could go to the next slide, please. So what are we looking at? We're looking at mitigation along the travel continuum. We really look at ourselves as domestic to global, then global back to domestic. So it's a whole continuum that we're looking at. So we know that we need to connect travelers with some resources. We also need to connect clinical providers as well. And so before folks are traveling, we have the CDC Yellow Book, which I think is really important for information around diseases that could be people could get during travel. We have the CDC Travelers Health website. And so on this website, I'm sort of going to move this around a little bit. We have our destination pages. So travelers can go to those pages, health providers can go to those pages, anybody can, to really see what are some of the concerns if someone were to travel internationally and get information around that. We also have information and travel advice and travel alerts that are there, and then the travel health notices as well. And I'm going to speak about that in a little bit later. And then also looking at the vaccinations and preventive medicines that people can take, and people can see that on our destination pages. It's actually one of the most hit sites at CDC. We get many millions, tens of millions of people that go every year to look at this site, but we really want to ensure that it's giving the information that is needed. So then during travel, we want to make sure that travelers have that information and that they're taking the precautions that they need. Also working with partners to detect and report ill travelers. And so we have networks across the globe that sort of communicate with each other. And then also after travel, sort of messaging that can be used as people are coming back into the United States, and then guidance for clinicians or evaluating ill travelers as they go. So next slide, please. So when we're looking at some of the surveillance aspects they're having, we want to make sure that there's better data and better information that we're having around travelers and people that are globally moving. We look at information that we're collecting. We also work with the WHO, the World Health Organization, with health ministries, and then also our overseas CDC program. So working very closely with Lyle's group, with Monica's group as well, and others across CDC. But some of the things that we have is GeoSentinel network. And so this is, as you can see, a worldwide clinical care-based network for surveillance and research of travel-related disease. And then we also have a G10 consortium. So this is a health clinics across the US that are looking at the role of travelers in the spread of pathogens, and also they help deliver pre-travel care. I think for the G10, as I said, it's sort of a consortium on pre-travel. We have the Heading Home Healthy program. So this is something that folks can go to and really looking at, and this is tied to sort of our travel website. Information about if I'm going somewhere, how can I best protect myself, protect my family as well. And also giving information to clinical providers through this healthy program. So next slide, please. I spoke a little bit about the Yellow Book, and then also this is the websites that you can see about our destination pages. Again, this is sort of our most accessed areas, one of the most accessed areas at CDC. To the point that was brought up earlier, the site that's hit the most frequently on this is around yellow fever. So a lot of people are trying to get information on that. We want to make sure that this information is readily available and easily accessible, and also that it's the right information. So we're always looking for feedback from partners and others to ensure that we're getting out the information that they need in a timely manner, and also that they can access it where they are. Next slide, please. So I spoke a little bit about our travel health notices. This is really about informing U.S. travelers and clinicians about global health risks, such as outbreaks or other events, other gatherings, natural disasters. Here you can see some of the criteria that we use for our travel health notices. This is disease outbreaks in a country or in a region, sporadic cases of diseases in unusual or new geographic locations, disasters, severe environmental health risks or infrastructure damage that could affect travel or people that are on the move. And then wanting to make sure that we're giving information around mass gathering events that can lead to disease outbreaks. As an example, Hajj that happened recently, we wanted to make sure that people had the information at their fingertips so that they could travel safely and healthily across. And next slide, please. I wanted to talk a little bit about our port health protection system. So we're unique in this respect is that we have stations across the United States. So we have 20 stations at 20 ports of entry across the United States that actually cover all the POEs. There's about a little less than 350 of them. And these are supporting state and local health departments, supporting airline authorities, airport authorities as well, and our interagency space. Again, around safe and healthy movement of people. We are covering these ports 24/7. Again, if there's an ill traveler or something that's happening, we want to make sure that we're able to respond quickly and that we are there to support our partners on the ground as well. We have the life-saving drug release program and distribution program at those ports of entry. Before there was some, we had diphtheria and artesunate. And now it's more around the HBAT program for botulism as well. So you want to ensure that there's distribution of these life-saving drugs in a very timely manner to prevent any morbidity or mortality associated with disease. So next slide, please. I wanted to discuss a little bit of our presumptive parasitic treatment program for US-bound refugees. So we noticed that intestinal parasites, being common in the tropics and subtropics, were affecting a lot of our US-bound refugee populations. An example of this was that US-bound Somali refugees, 38% had intestinal parasites and 7% had malaria. Another assessment of refugees from Sudan, 44% with schistosomiasis and 46% with strongyloides seropositive. So based on this evidence in 1999, CDC recommended an overseas presumptive parasite treatment schedule. You can see the schedule here. This was an approach based on the Global Mass Drug Administration programs. And we had the different program treatment protocols based on the EPI that we were getting. Next slide, please. So what we saw, and so we instituted the program, and then they did a post-program analysis of about 27,000 refugees that were arriving in Minnesota. I think everybody can see here, there was a dramatic decrease in the burden of disease in these populations. And I think this is one of the modalities that we can use to help, again, travelers that are moving, coming into the United States, especially where we have touch points for those travelers. I won't go into the depths of the numbers on the slide because I think everybody can read them, but I think what you can see here is sort of stark a representation of a good program at work. And so next slide, please. I think one of the last things I wanted to touch on is sort of what are some innovative things that we've done for traveler engagement. We've done some geo-targeting technologies to send public health messages to travelers. So using geofencing and social media technology, how can we make sure that people coming in are getting information they need through different modalities of information that, how they take in information? And I think we were able to demonstrate in a couple of areas that this really was working. And so people were using this and accessing these sites. We're in the process of evaluating this a little bit further to see, is this a good tool that we can use to make sure that people are getting the information they need? Our text illness monitoring tool, or TIM tool, and some folks might have used this if anybody is engaged with some of the outbreaks abroad, is people coming back and they're linked into the system, making sure that they're getting information in a text-based modality. We use this for the 2022 Uganda Ebola outbreak and an example of that. And then lastly, our traveler-based genomic surveillance program for early detection. 3 modalities associated with this. The first is a voluntary anonymous swabs. The second is wastewater on airlines, and the third is wastewater at the airports themselves. This has really helped us get information. It started around COVID-19, and then we've expanded it to a couple of other pathogens as well. Is how can we understand what potentially is coming into the United States? And as you can see there, it started with keep COVID-19 grounded, but how do we keep disease grounded? Sorry, we love puns over here in DGMH, so we do appreciate that. But I just wanted to say thanks to everybody, and thanks again for this opportunity. Turning it back to our Research America colleagues.
Yeah, thank you all so much for that fantastic presentation. A lot of great information there, and I think really ties all the threads of this problem together for everyone. So just want to remind all of the people on the call today that if you have any questions, please put them in the Q&A box or the chat, and we'll get to them soon. And I'll ask a few to kick us off here. You all touched in the presentation on, the unprecedented first time in 2 decades that we saw malaria cases, locally transmitted malaria cases last year in the US. We were already seeing unprecedented levels of dengue in Puerto Rico, and I saw last week there was some confirmed cases in the Florida Keys as well. So, just curious if you see these cases and these, new outbreaks as really moving the needle a bit on this conversation and leading to change in how we're looking at these diseases from a public health perspective, and also, making sure that we're investing in new initiatives and improvements. And also going to thread in a question that we got here in the chat, which is whether you all think that we'll see the success of some of these interventions that you all talked about in this decade, or do you think it'll take a little bit longer to see real substantial change?
Well, I guess I'll start with that. It's a long question, so I think the one thing is that it's clear that the methods that may have worked in the past no longer work. And I think this resurgence of dengue is a good example. At one point, because of yellow fever, people tried to get rid of the Aedes aegypti mosquito in the Western Hemisphere, which is an invasive mosquito. And they were actually pretty successful, and they got rid of it in many countries around the world with DDT. And obviously, we don't want to use DDT anymore. There's widespread insecticide resistance, for example. So we really need new methods of control that will work in modern environments. And we've had some success with some of these. For example, if you infect Aedes aegypti mosquito with a bacteria called Wolbachia, which is present in about 40% of all insects, so it's around anyway. And if you spread these mosquitoes with Wolbachia around, it's been shown that for some reason that nobody really quite understands, when these mosquitoes are infected with Wolbachia, which is a parasite of mosquitoes, basically what happens is these mosquitoes are much less likely to transmit any viral infection, such as dengue, yellow fever, whatever. And so people, when they put these Wolbachia infected mosquitoes out in environments like in Indonesia, we're doing this in El Salvador now, and in many other countries like Brazil, what it shows is that dengue incidence goes way, way down. And so once the Wolbachia is in those mosquitoes, it stays there and gets passed on from generation to generation. So once you do it, you can really reduce the rate of dengue. So that's one good example of how a brand new intervention that's environmentally friendly can really reduce incidence of many of these viral diseases. Maybe Monica wants to take it over.
No, I think that was very helpful, Lyle. I mean, I think I already mentioned some of the novel methods. There's been a flattening globally of our progress in malaria control. So we're also needing to look for new methods. And some of the ones I had mentioned, for example, spatial repellents are looking pretty promising. So we're constantly having to address this, as well as, our President's Malaria Initiative is always closely looking at surveillance for insecticide resistance and adjusting as we need to.
Oh, thank you. Dr. Parise, I'll also piggyback off of some of your slides earlier too. You talked a little bit about some of the major barriers that we really are currently facing to appropriately even quantifying the threat of these diseases as they're spreading further north. One being, just a general, we haven't really been surveilling for them. So we sort of have a lack of that data. And then also, following that, a lack of general awareness among, medical professionals to look for these diseases in the clinic, or, even a lack of awareness among the public to think about, should I be wearing mosquito repellent all the time? Should I be checking myself for ticks every day? So curious, thinking of those, how the CDC is working to address those barriers actively, and where you see the most potential to make strides on those.
Maybe
yeah, David. No, go ahead, David. I think you have the broadest example, so please go ahead.
I'll be broad, and then maybe I'll turn it over to Monica if that works out. How about that? Again, I'll use Lyle's start. It's a broad question, but I think it's really important as we look into this. From maybe the surveillance aspect, as we're looking globally, and some of this, Monica has to think a little bit more specifics on this, is CDC is doing a lot, I think, in that binational sense, with countries themselves, also with multilateral partners, or bilateral rather, and multilateral partners, to help improve surveillance systems globally. If you look at the global health security aspects of this, and within that is a lot of these communicable diseases. And certainly when it comes to NTDs, is ensuring what is the burden is, and how are we best understanding that's in these populations. And also, there's the component piece of populations on the move. So we have mobile populations that are going, and they might have different sort of illness or disease sort of demographics, if you will, on this, and understanding those populations as well. We're working closely with Monica's group as we look at Central America as an example of this, if we're looking at malaria and that, and what is sort of risk in these populations and risk in populations that are not mobile and mobile populations for carrying disease as they come in. And then as we get better information around surveillance, as I was bringing up, we have the travel health notices as well. We have alerts. And then we also try to make sure that we're updating in real time our destination pages on the CDC website. Then I'm going to turn to partners as well on this one to say we would love partners to amplify this resource to let people know. We're also going through our sort of clinical outreach calls. I think it's the community outreach and communications activity, or COCA calls, if something pops up, making sure that we're getting that out quickly to providers, and then making sure that we have it on our websites and then using other platforms, social media platforms for that. We have the health alert notices, the HANs that go out as well. So I think there's a lot of pieces of this, but we're always looking for other ways where we can better sort of get our information out to populations that we can help and be helpful to engage. So I'll start there. Maybe Monica, if there's anything else.
Yeah, no, I think you said it well. I mean, I think, public health, really getting to these people is local. So while as the US government, we can provide the overarching assistance, the health departments and countries' health departments and partners are just critical.
Great. I have a third broad question for you all, and then I'm going to turn it over to my colleague Jacqueline to ask some of the questions that we've gotten in the Q&A chat. So my last question is, what would be on your wish list to address these diseases? Like any research and development, innovation, vaccine, therapeutic, vector control method, what would be, in your opinion, for all three of you, what would be the most impactful thing that if you could have it now, you would want it?
Yeah, I'll start with answering that. And I'm going to cop out and say there's not one thing, simply because I think there's no magic bullet here, at least with the mosquito-borne diseases that I deal with. But the fact is that in combination, we can make real headway. So for example, if we had better environmentally friendly ways of controlling mosquitoes or ticks, in combination with a vaccine, in combination with depending on the circumstance, these Wolbachia infected mosquitoes, and then there's a whole bunch of other possibilities. But in combining one or two of these things together will have a really big impact, I think. And this is actually one of the most exciting times. I've been working in vector-borne diseases for a pretty long time. And I'm really, really excited about what's happening right now. We have better methods of diagnosis. We have new and emerging methods of control of vectors. We have new vaccines coming online. So I think the future is looking really bright to really have a big impact on many of these diseases.
I guess I can jump into that. I mean, I totally agree with the need for various modalities to help us. And I think I mentioned a few of those on the malaria front. I do want to make the point of need for better drugs. I mean, when we look at some of these diseases that are in the United States, so we're lucky for parasitic diseases. We only have one vaccine. It's not approved in the United States or would be appropriate for US travelers. But we do have drugs. I mean, that is one advantage that we have for the parasites. But some of them are so antiquated. I mean, we're still using antimony, extremely toxic drugs to treat leishmania. Our Chagas disease drugs leave a lot to be improved. They're very toxic. But we need to get rid of Chagas in patients that have it. So I think that's another need that we have as we look across, what we would like to see.
All right, mine's going to be pretty obvious. It's going to be around the traveler themselves. And I think that this is the piece. And if I woke up and I got exactly what I wanted, it would be for people to sort of read, like, I'm going to go somewhere. Let me look and see what I should do to take care of myself and take care of others. I think we have a lot of preventive methods right now to help us. And how do we engage, and how do we engage people to do that? Behavior change is hard, but it is possible. And that would be my wish. So if I get to skip through the whole behavior change aspect, it would be that. And all the other aspects that we're at.
I love it. Responsible traveling. So with that, I'll tag my colleague Jacqueline in to take some questions from the Q&A.
Thank you, Tori, and thank you all for this great conversation so far. So we have a lot of questions that came in. I'm going to try to get to as many as I can. So for our first one, I'm thinking a lot of people in the audience are thinking this. What purpose do mosquitoes have in nature other than being a human pest?
That's a great question, and I can't think of a single purpose of a mosquito contributing to nature. But I think one of the things that's important to realize is that many of the mosquitoes that are causing all these problems shouldn't be there. Aedes aegypti, for example, that spreads yellow fever, Zika, dengue, chikungunya virus, which is a horrible human-biting mosquito, shouldn't be anywhere in the Western Hemisphere. It was imported. And so many of and it's actually expanding. For example, the new cases of dengue that have appeared in California and in Arizona, it didn't exist there until recently. We don't know why it's invading the Western US like it is right now. But these are invasive pests that shouldn't be there. People talk a lot about, well, if you kill off all the mosquitoes, will bats die or something? I mean, bats will starve if they depend on mosquitoes for food. So there really is not a real good known reason or benefit of mosquitoes, particularly invasive ones, in the environment.
Thank you. Does anyone else want to chime in? Okay, I will go to our next one. So this is a multi-part question in the Q&A, and I hope I'm saying this mosquito name correct. The Aedes mosquito is known for transmitting several viral infections to humans, chikungunya, Zika, and yellow fever. What risks do co-infections pose? Are co-infections becoming more common? And could you all explain how co-infections with dengue impact morbidity, mortality, or recovery from complications like hemorrhagic fever?
Yeah, that's a great question. And we do know that co-infections do occur. It's not necessarily that the same mosquito infects you with two viruses. When these viruses are co-circulating, you get bitten by mosquitoes all the time. So the possibility of different mosquitoes biting you, each carrying different viruses, is there. Fortunately, these co-infections are pretty uncommon. We rarely detect them. So we don't really have really great solid data on what the impact of getting two of these at the same time actually is. One might imagine that it's not a good scenario, but there's not a whole lot of data.
Got it. Thank you. So for our next one, again, I hope I'm pronouncing this right. Why isn't Wolbachia being used more for dengue in Puerto Rico this year?
Well, we want to use Wolbachia in Puerto Rico because we think it will work like it has elsewhere. It has to undergo, it's not licensed in the US yet, at least the Wolbachia replacement kind of strategy that I was talking about has not been licensed yet. And so we're currently in discussions with the Food and Drug Administration who would license it and bringing that forward for licensure. But that will probably be a couple of year process. We're hoping to speed that up, but that's the main hurdle at this point.
Great, thank you. And I believe I have time for just one more, but it's a really good one. Is the CDC working with the White House's Pandemic Preparedness Office to address controlling NTD spread? How concerned are you all about any of these diseases spreading more widely and quickly than they already are?
Monica, do you want to take that one, or I can take it?
I can just say, very briefly, when we had the malaria outbreak, we had briefed that office. At that point, jointly we decided that we didn't think the spread was going to be extremely widespread on the malaria cases. So we sort of left it at that, and that we would stay in touch. We have not been in touch with them about any of the other NTDs in the United States.
Yeah, and we have been in touch with them, particularly regarding the dengue outbreak in Puerto Rico that we're having right now, and the threat of dengue into the continental United States and other U.S. territories. So we have been in touch with them.
Great. Well, thank you so much. I think I have time for just one more, and then I'll turn it back to Tori. So a question for each of you panelists. What vector-borne disease do you worry most about surging in the US, and why? And if you also have an answer for globally.
Yeah, so I'll answer that for at least for the things I deal with. So it depends where you are in the US. If you're in the continental US, I really, really worry about West Nile virus outbreaks. Although we're coming on the 25th anniversary of West Nile virus in the US next month. So this is not something that came in yesterday, but the reality is it continues to cause large outbreaks, considerable morbidity and mortality, and has threatened the blood supply and is spread by transfusions and transplantation, organ transplant. So it's really a bad, persistent problem. And with the temperatures in recent years warming, it's only exacerbating this problem. In the U.S. territories, I worry about dengue, and we're having big outbreaks right now, and they're getting worse. And so it just depends where you are, but these are the two things that I most worry about.
Yeah, I can just briefly. I mean, I don't think malaria is going to take off. And I mean, that's largely because of the economic development. And we don't live in houses where we have, we live in screened air-conditioned houses and don't have the contact with that vector like we used to have many years ago. One of our diseases, and we don't have for many of these diseases, the big, huge numbers that Lyle's division has, but babesiosis is a problem for us. That is one, tick-borne spread where people go out in nature and are exposed.
I'm going to go in a different direction, and this is something where we work with Monica's group. Is from ours, we're looking at malaria, and this is because it's a lot of people that are leaving the United States when they leave the US. So thank you to the person who added the comment about checking the website. Appreciate that. But we're really looking at sort of the visiting families and relatives, folks that are going out, making sure that they are taking precautions and not bringing back an unwelcome guest with them. And so malaria is one of those. And so that's how my mind sort of goes.
Great. Well, thanks. And I think everyone agrees, take home message is travel safe. So I'll turn it back to Tori.
Yeah, thank you everyone for joining us today and for your thoughts and participation in the chat. Before you go, please take a look because we're having an Alliance discussion again this Thursday, July 11th at 1 p.m. Eastern with Quinn Ritchie, the Legislative Director for Representative Mike Kelly. We'll be having a conversation on congressional efforts to increase access to clinical trials and the potential impact of the Harley-Jacobson Clinical Trial Participant Income Exemption Act. The bipartisan bill would exempt clinical trial payments received by participants from taxes to help make clinical trials more accessible to everyone. And thank you again for joining us today. We look forward to seeing you again soon, and have a great afternoon.
Thanks all.
Good, thanks, everyone.